Hello, my friends. Today we're talking about patient-controlled analgesia. It's not super complicated, but if you've never worked with PCA, this is probably something you want to watch so that you can get those NCLEX questions correct. So stay tuned. That's coming right up. Hello, Clinic Review families. Dr. Sharon with Clinic Reviews. My dogs heard me talking and came rushing in here to be a part of the program, and they will eventually lose interest and wander out. So you may see their tails for a little while. Hey, I am talking with you today about patient-controlled analgesia. This is not rocket science, but if it's not something you've worked with before, then you can learn a little bit about it today. Patient-controlled analgesia is a device that's set up and the patient has their own button to push it to get their own medication. Patient-controlled analgesia, there are controls to it. So it's not like the patient can get medication every time they push their button, okay? So what happens is the nurse puts the syringe in the PCA device, and it could be hydromorphone, it could be morphine, it depends on what the doctor orders. They put that into the PCA device, and they set limits on that. So they set a 4-hour lockout limit. Like they may say, if it's morphine, they may say they can have a maximum of 4 milligrams in 4 hours. Okay, so that's their lockout limit. So no matter how many times they push it, they can never get more than 4 milligrams in 4 hours. And then they set a demand dose. So maybe a demand dose is 0.2 milligrams of morphine, and they can get that demand dose every 10 minutes. And they set it for every 10 minutes. They set the demand dose as 0.2 milligrams. They set the 4-hour lockout dose as 4 milligrams. And they can change it. They could be every 6 minutes. It could be a demand dose of 0.5 milligram. It depends on what the doctor orders, right? So those are the 3 most common things. And sometimes then there's a basal rate. Basal rate is a low level of the medication that's given continuously. So they can demand it, they can push it and get a demand. They can also get a continuous basal rate. It just depends on how it's ordered, and the nurse is responsible for putting those things into the PCA device. And that's our responsibility. And then we have to teach the patient how to use it. So they have to be able to learn how to use it. They have to be awake enough to learn how to use it. They have to have the ability to learn how to use it, and they have to have the dexterity to be able to use it. So those are the key things that you need to know about when you're doing that. Now, you know, this Clinic Review channel is part of the greater Clinic Review organization. We do one of the most phenomenal NCLEX reviews in the entire universe, in my opinion. And it's done by Mark Klimek himself. He's the GOAT. He's phenomenal. He developed this NCLEX review. It's based on his way of thinking. He sees the world in patterns, and you're going to find it to be extremely helpful. There's nothing else like it out there. He's taught me everything I know about NCLEX review. What we do on this channel is not the same as what you get in his online on-demand NCLEX review. So you can go to clinicreviews.com, sign up for that. We also have a streaming service, and we have a monthly small group tutoring package that you can get. It's actually live tutoring online through Zoom. Mark does 1 or 2 of them depending on the month that you do it, but he'll do at least 1 of them. I do 1 or 2 of them depending on whether Mark wants to do 2 or 1. If he doesn't want to do 2, I do 2. And then Piece of Art does 1. So that's kind of how that works out. And I recommend it. So let's go ahead and get started. This is from the Blue Book. PCA is in the Blue Book. It's not as part of the Clinic Review itself, but it is in the Blue Book. The Blue Book is a set of facts that you have to know, but there's no NCLEX questions associated with it. So I take the facts in the Blue Book, and I do recommend purchasing it. You can get it at Amazon. It was written by Mark Klimek himself, and it's called The Blue Book. Just type in Klimek Blue Book into Amazon. It'll come up. You can order it. And then I do NCLEX questions to show you how you can take the content from the Blue Book and apply it in questions. Okay. All right, let's get started. A post-op patient is using PCA with morphine. The nurse notices the patient is pressing the PCA button frequently, but still reports unrelieved pain. What is the most appropriate nursing action? So the most appropriate nursing action is the best action. If we can only do one thing, what's the one thing we have to do? So they keep pushing it. But they're saying it's not relieving my pain. So let's see what we got. Encourage the patient to wait longer between doses. Well, that doesn't make any sense. Reassess the patient's pain and notify the healthcare provider for possible adjustment. Okay, that's a possibility. Instruct the patient to use non-pharmacological pain relief methods instead. Maybe. Inform the patient that the PCA is set correctly and cannot be changed. All right, that's not a therapeutic statement. That's ignoring what they're saying. It's saying, you're wrong, I'm right. All right, so we're going to cross off A and D. Now, when I get it down to 2, which is usually the way it is with a best question or a most appropriate question or your highest priority question, I have to say I'm going to do one, but I'm not going to do the other. And then I say which one makes more sense, which is safest, which is most consistent with what I know to be true about nursing practice. So I'm going to do B, but not do C, C, but not do B. So I'm going to reassess the patient's pain and notify the healthcare provider, but I'm not going to instruct them to use non-pharmacological pain relief methods instead. Okay. I mean, I'd like to instruct them to use non-pharmacological pain methods, but I don't want to do it instead of the PCA. So I'm okay with not doing C, or I'm going to instruct the patient to use non-pharmacological pain relief methods instead of the PCA, but I'm not going to reassess their pain and notify the healthcare provider. That doesn't make sense. It doesn't make sense. If they're on a PCA, it's not really working. It doesn't make sense. I go, okay, well, let's just do something. Let's just do non-pharmacological. Let's see if we can get you more comfortable, reposition you in bed. I mean, I'd want to do that, but I have to reassess their pain and notify the healthcare provider to see maybe they want to change the medication, switch it out of morphine, put it in hydromorphone or something like that, right? So that's the best answer. When programming a PCA pump, which settings must the nurse verify? Select all that apply. Now, I told you this. So let's see if you remember what I told you. Basal rate. Yes, basal rate is that continuous rate that's going in the pump. And remember, we're talking about programming the pump. This is what we're talking about. Basal rate is a programmed rate in the pump. Bolus dose. Yes. Bolus dose is that dose they get when they hit the button. That's called the bolus dose. So that's part of the programming. Lockout interval. Yes, lockout interval is how long they have to wait to get another dose. So what happens is they push the button and you hear a beep and they know they just got a dose. They can keep pushing it. But if it's got a 10-minute lockout, they're not going to get anything. And they know they're not getting anything because it doesn't beep. Okay. So beep, beep, right? Beep and then blah, 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 and then nothing. And you do teach them, you're like, it can keep hitting the button, but it's not going to give you anything, sis, right? So that's the lockout interval. So that's something I program in. Patient's respiratory rate. That is not something I program in. Do I want to assess the respiratory rate? Yes. But this is about programming the PCA pump. I don't put that into the program. Maximum allowable dose. Yes. I put that in. That's part of the programming. Level of consciousness. I want to assess that, but it's not part of the programming. Okay. So this is about programming. Those are the 4 things that you put into the PCA when you program it. And that is the nurse's responsibility based on the doctor's orders. A patient using a PCA pump begins to exhibit signs of respiratory depression. What is the nurse's immediate action? All right. This is an interesting question because they don't give us any hard data. They give us the problem. They don't say, here's their respiratory rate, here's their O2 sat, or anything like that. They just say it is respiratory depression. So if they're exhibiting signs of respiratory depression, I have to believe what they're telling me. So don't go, well, what does that mean? It means respiratory depression. So it's a negative thing. What is the most common side effect of opioids? It's respiratory depression. Now, respiratory depression may be really severe. Respiratory depression may not be so severe, but if they're going to give us this word, I'm going to assume it's a clinically significant respiratory depression. Okay. So do I want to stop the PCA and administer oxygen? Maybe. That's a good option. I don't know what the other options are. So we're going to keep A on our list, decrease the PCA dose. Okay. Yeah, I may want to do that. We'll keep it on the list, document the findings and continue to monitor. Well, I do want to do that, but that's not what my immediate action. Encourage the patient to take deep breaths. I mean, I may want to do that, but that just doesn't make a lot of sense to me. That's not what I usually do. So I'm crossing off C and D. Well, it's actually an immediate action. So this is actually an immediate action question. This isn't a best question. It's immediate. So first, what do you want to do first? So do I first want to stop the PCA infusion, administer oxygen, and then decrease the dose? Or do I want to decrease the dose and then stop the infusion, administer oxygen? Well, obviously I'm going to stop it, administer oxygen, and then I can reassess them, probably call the doc, and then decrease the dose. That's probably where that's going to kind of play out. So this is my immediate action. If they're respiratory depressed, you got to stop it immediately. Okay, so just turn it off and administer oxygen or whatever needs to be done, and then kind of reassess where we go from there. The nurse is preparing to discard a partially used PCA drug cartridge containing a controlled substance. The correct nursing action at this time is what? So this is really, it's not specific to PCA. This is specific to discarding any controlled substance. And this is not about what's your hospital policy. There is a nationally recognized way to discard controlled substances. Okay. So this is not, it's not like if you pull a pain pill and then the patient, and you don't open the package and you take it into the patient, I pulled a Percocet for you. And they go, I don't want it. I've got an unopened pain pill. It's not used. I'm probably going to return to the pharmacy. I'm not going to discard it, but we have a partially used cartridge. This is not an unopened cartridge. This is a partially used cartridge. So I'm not going to return it to the pharmacy. So what am I going to do? Return to the pharmacy? No, that's not what we do. Dispose of it in sharps container without documentation? Absolutely not. Discard it with a witness and document according to policy. That's what we do. We have to discard it with a witness. Now, usually discarding it with a witness, there's usually a container of, I don't know what it's called, but it's a liquid that deactivates the medication. Usually if it's a liquid, you put it into that, you empty it into that container, you document it. They have a witness there. And y'all, I'm telling you, in real life, do not ever discard this stuff without a witness, ever. They will come back at you and accuse you of stealing it when you didn't do it. So don't ever discard it without a witness. You have to do it and then document it according to policy. Flush it down the sink to prevent misuse. No, that's not how we do it. We have to discard it with a witness and document it according to policy. Patient on PCA with continuous basal rate is found to have a respiratory rate of 8 breaths per minute. What is the priority nursing intervention? So that, by definition, is respiratory depression. Anything under 12 is respiratory depression. We usually say 8 is kind of where we need to take a more aggressive action. So 8, I need to take more aggressive action. So what am I going to do? Increase the lockout interval on the PCA pump. I mean, they've got 8 breaths per minute. I have to be more aggressive than just decreasing the medication rate. Stop the PCA infusion and stimulate the patient. That looks like a good idea. Notify the healthcare provider after completing documentation. Well, I will want to do that. Administer prescribed naloxone immediately. No, I don't need to do naloxone immediately. I need to see if I can stimulate them first. So I'm going to cross off D and I'm going to cross off A because that's certainly not my priority because I have to stop the PCA. So I would probably stop the PCA, stimulate the patient, and then notify the healthcare provider. But my priority is stopping the PCA. I have to stop the PCA. I can't let that, because they've got a basal rate, I can't let that keep running. The following patients have all been ordered to have PCA analgesia for pain. Which of the following would the nurse question the order? So we've got all these patients, they've all got PCA. Which one should not have it, or I'm going to question it? A patient in hospice with bone cancer, a diabetic patient with severe ischemic leg pain, an 80-year-old patient with severe chronic back pain, or a postoperative patient with COPD. All right, so what is a contraindication for PCA? PCA is used for acute pain, it's used for chronic pain, it's used for post-op pain, it's used for cancer pain. These are all appropriate things to be used for. So what is a contraindication? Contraindication is really a significant respiratory problem. And patients with COPD, especially with COPD, if you slow their breathing down, they may start to retain CO2. So we're really not eager to have a patient in control of their own pain medication when they have COPD. There's nothing, the age doesn't make them ineligible. The diabetes isn't a problem. Certainly a patient in hospice may need a PCA. That's all fine. It's the COPD that is the problem. So when you're looking at people who you may question having a PCA, your chronic respiratory problems could be the ones. A patient asks how often they can press the PCA button for pain relief. What is the nurse's best response? So a best response means I'm looking for the best answer out of all the answers we have here. Press it every time you feel pain. Yes, the machine will deliver medication each time. I like it, press the button every time you feel pain, but that doesn't mean the pain will deliver it at each time. So I'm not crazy about A. Press it no more than once every 4 hours. Well, that's just wrong. It's usually every 10 minutes. You can press it as often as needed, but it will only deliver medication as prescribed. I like that a lot better. C is way better than A. Wait for me to tell you when you can press a button. That's not true. Okay, C is the correct answer. So out of all these options here, C is correct. Remember, you don't want to pick an answer that's only half right. The entire answer has to be correct or the answer is not correct. And so C is the correct answer here. Patient expresses concern about becoming addicted to opioids through PCA use. What is the nurse's best response? Addiction is rare when opioids are used for acute pain as prescribed. We can stop the PCA if you're worried about addiction. You should focus on recovery rather than worrying about addiction. Addiction only happens with long-term use, so you don't need to worry. So I'm going to cross off C and D. Those are not good answers. Now, here's I'm going to tell you, addiction is rare when opioids are used for acute pain as prescribed. That is a true statement. So it says, what is the nurse's best response? Now, is it true that we can stop the PCA if you're worried about addiction? Yes. However, usually as an NCLEX testing strategy, when there's a true statement, as long as it's a therapeutically true statement, it's often the right answer. And A is actually true. Now, A is the correct answer in this case. Now, I'm going to go away from testing here for just a second. Y'all, in real life, opioid addiction is a serious problem. It is much less likely with a PCA for short-term acute pain. It is unlikely to happen, but it could happen. And I'll tell you what I would do in real life. I would say, tell me more about why you're concerned about that. Because they may have a history of family drug abuse, and maybe it's best to not use a PCA. So on a test, A is the best answer because it's a true statement. In real life, I would say, tell me more about why you're saying that. And if it bothers you that much, let's talk with the doctor about a different option for you. Because I would not want the nurse to ignore that if I was concerned about that, because that's a very serious problem. And I know people who have addiction problems, and I wouldn't want them to ignore that. A physician orders a PCA with hydromorphone, demand dose of 0.2 milligrams. So the demand is every time they push it. Well, they push it, say every 10 minutes. Lockout interval of 10 minutes. So demand dose, they get 2.2 milligrams, 10 minutes, no basal rate. So no continuous rate. Upon reviewing the PCA settings, the nurse notices a basal rate of 0.5 milligrams per hour programmed into the pump. What is the nurse's best action? So they're not supposed to have a basal rate, and they have a basal rate. Leave the settings as programmed and start the PCA. Well, if I do that, I'm not following doctor's order, so I'm not going to do that. Change the basal rate to 0 per the physician's orders. Well, that's following doctor's orders, so B is a good option. Call the physician to confirm the basal rate. I've got a doctor's order. I don't have to call. I've got a doctor's order. I don't have to call. Document the discrepancy and monitor the patient closely. Okay, what is the nurse's best action? Y'all, I have to change it to 0. That's the doctor's order. Listen, there are going to be questions on NCLEX. They're going to test whether you can follow a doctor's order. So don't ever pick an answer that shows you not following the doctor's order, okay? Unless the questions, if it says which order will you question, then you can question orders. But questioning orders means you think it's going to harm the patient. So you only question an order when you think there's harm. Now you clarify an order when there's an error to the order being written, but there's no errors to the order being written here. There's no unapproved abbreviations. There's no 0 after the decimal point, right? There's no reason to clarify this order. There's certainly no reason to question the order. And so we need to follow the order, and that's why we're going to do B. A patient with severe rheumatoid arthritis is scheduled for surgery and post-op pain management with PCA. What potential disadvantage should the nurse consider? Increased risk of post-op infection, higher likelihood of allergic reaction, reduced need for nursing interventions, difficulty in operating the PCA due to the limited hand mobility. Well, why did they bother to tell us they had rheumatoid arthritis? Where is rheumatoid arthritis? It's often in the hands. You can see, start to see hand deformities, pain, and so forth. So they have severe rheumatoid arthritis. They don't just have rheumatoid arthritis, they have severe rheumatoid arthritis, y'all. So is there any reason to think that would increase their risk for post-op infection? No. Any reason to think they have a higher likelihood of allergic reaction? No. And reduced need for nursing interventions is not necessarily a disadvantage. And I don't even know that that's a true statement anyway. I mean, we're still going to have nursing interventions. They may not be pain interventions, but we're still going to have nursing interventions. Could they have difficulty operating the PCA with limited hand mobility? Yes, it's the only answer that makes sense. I know it's not rocket science, but sometimes the questions that are least difficult cause us the most angst because we go, wait a minute, that's too easy. Maybe I'm missing something. You're not missing anything, y'all. That's the right answer. Which patient is at greatest risk for adverse effects from PCA morphine? 25-year-old with a history of asthma, a 50-year-old with obstructive sleep apnea, a 35-year-old with hypertension, or a 60-year-old with controlled diabetes. So the age doesn't really matter. So C and D are out. I'm crossing those off. Those aren't respiratory problems. So would you be more concerned about a young person with a history of asthma or an older person with obstructive sleep apnea? Because what's going to happen when they're using the PCA? Do you think they're going to sleep? Yes. Do you think it could depress their respiratory? Yes. So when you think about risks, I would just have to go with B. I know A is a respiratory issue, but we don't know that they're going to have an asthma attack while they're in the hospital or while they're on the PCA. So asthma, especially if it's controlled, you shouldn't have any problems, whereas obstructive sleep apnea, that could cause some problems. So I need to be more concerned about that. After discontinuing a patient's PCA pump, what is the appropriate action for disposing of the remaining opioid medication in the cartridge? So I put this on here because the answer is the same, but it's worded differently. And I want to show you that when you test on the NCLEX, you test conceptually. So you say, I know conceptually what the right answer is. Even if the words are slightly different than what I'm looking for, I'm still going to pick the answer that conceptually is consistent with what I know I need to do. So we have a partially used cartridge, which means I can't just send it back to pharmacy. Okay, I have to dispose of it. Return to pharmacy. No. Flush it down the sink with hot water. No, there's no witness there. You got to have a witness. Discard it in a designated pharmaceutical waste container. Yes, with a witness. There we go. Witness, witness, witness. Mix it with regular trash to prevent diversion. No. Okay, so I'm just showing you that the same concept, the right answer is the same answer, but it's slightly different wording. A nurse is teaching a patient about PCA. Which statement by the patient indicates a misunderstanding? A misunderstanding. So we're looking for a false statement. I control my pain medication by pressing the button when I need it. Well, that's a true statement. I can let my spouse press the button if I'm sleeping. Okay, y'all, that's not right. They're not supposed to let their spouse. In fact, if you walk in and the spouse is pressing the pain medication, unless it's like a patient who's like, my hand hurts and I can't do it. If they're telling their spouse to press it, maybe. But if they can't physically do it, they shouldn't have it. The spouse is never supposed to press it. If you walk in the room, the spouse presses the button, you need to say something like, I'm sorry, you can't do that. We can't let that happen. So we may have to switch pain if the spouse is pushing the button. The machine has safety features to prevent overdose. That's not a misunderstanding. That's a true statement. I should report if my pain isn't controlled after using the PCA. Well, that's a true statement. You should do that. So we cannot let the spouse press the button. And I'm a spouse who would probably press the button on behalf of my husband. I'm just telling you, I am a very non-compliant patient, very non-compliant spouse. I would do everything you told me not to do. So I'm not judging anybody. I'm just telling you the way it is. Okay? All right. Well, I hope you have a great rest of your day. I hope this was helpful. Good luck on your NCLEX. Good luck on your HESI or whatever other standardized test, ATI, whatever standardized test you're taking. These strategies are going to help you. So I wish you all the best. Have a great day. Thanks for being a part of the Clinic Review family.